Dr. Wilkins attended medical school at Johns Hopkins University and completed her general surgery residency at Duke University Medical Center. While she was at Duke, she had the privilege of training with Dr. Kurt Ludwig, who incidentally was the first colorectal surgeon to work at Duke. But many universities in the pre-90s didn't really have a lot of colorectal surgery residents. So thankfully that's changed in the last few decades. Her dedication to colorectal surgery started at that time under Dr. Ludwig, and she completed her colorectal surgery residency at Rutgers Robert Wood Johnson. There she worked under Dr. Eugene Salvati, obviously one of the founding fathers of modern colorectal surgery. She's lived in New Jersey since, completing the colorectal surgery residency at Robert Wood Johnson in 2003. Since that time, she's been honored to train 3 colorectal surgery residents every year at that program, so you can do the math on that. It's a lot of people. Big difference in the colorectal community. She currently serves as the assistant program director and head of the resident research at Robert Wood Johnson. While her practice encompasses all aspects of colorectal surgery, she's particular interest and expertise in all aspects of colorectal surgery. She serves as the current president of the Eugene P. Salvati Alumni Society. Besides running a very busy clinical practice and training the colorectal surgery residents, she has been very active in New York, New Jersey, and Pennsylvania societies, and as I mentioned, she's the past president of this society. We're very fortunate this society produces a lot of presidents of the ASCRS over the last couple of years. She has served on numerous committees in the ASCRS. She was the program chair of the annual scientific meeting for the ASCRS in Los Angeles in 2016. She served as the chair of the self-assessment committee, the leadership task force, and has been involved in the development of the ASCRS Surgical Leadership Institute. She has served on the ASCRS Executive Council from 2004 to 2021, and she was the ASCRS treasurer from 2022 to 2024. She's currently the ASCRS vice president and the will be president next year. So she's going to be hosting the ASCRS 2027 tripartite meeting in New Orleans during her term as president. She's been happily married to her husband, John, who also joins us here tonight. Thank you for coming, John. Since 1997. During her free time, she enjoys traveling, hiking, and spending time on the water in her boat, Wilkins in the boat. Well, Dr. Wilkins is here to give us a great talk about knowing your worth, and I'm excited to hear what she has to say.
Can you hear me okay? All right, thank you. Well, it's an honor to be here. I've been coming to the Union League to this meeting since 2002. When I was a fellow, I think I haven't missed the Bacon Oration thing in all those years. And I'm amongst friends, so I'm really happy to be here. So thank you for the honor and the invitation. And Dr. Kupchandani, thank you for your talk on Dr. Bacon. I know Dr. Salvati would be proud that you're still coming to the meeting and you're here with us. So thank you very much. So we'll see how this talk goes. Kind of rally up a little bit, hopefully. But I'm going to speak about knowing your worth, empowering colorectal surgeons. I don't have to go over Dr. Bacon again, since Dr. Kupchandani just did that, but it's because of him that we're all here at the Union League. So I started thinking about, in the last couple of years, I talked to friends, colleagues around the country, and people sometimes are sad. They love taking care of patients. They love what they do on a daily basis, but it's really hard. And why? Why is it so hard? There's high burnout rate among surgeons, especially subspecialists. And this can lead to early departure from clinical medicine, early retirement, and physician shortages. And it becomes a never-ending cycle. What are some of the reasons why we have this? Some people talk about EHR and the documentation burdens, productivity measures with RVUs, lack of autonomy in our hospitals that are dominated by administrators who frequently are not physicians, the emotional toll it takes, the long path to training we have. We're highly skilled, but there's a sense of invisibility sometimes in our hospital systems. There was a McKinsey survey that found that about 35% of physician respondents said they were likely to leave their current roles within the next 5 years. And of those, 60% of them said they were likely to leave clinical medicine entirely. That's disturbing. In a 2024 MGMA poll found that 20% of medical groups have reported having a physician leave or retire early in 2024 due to burnout. So what are the pressures that we all face? And we're all facing them to some degree. It doesn't matter who you talk to, no matter where they live, no matter what kind of practice, it's always the same thing. There's declining professional fees for the complex life-saving work that you do. The RVU values stagnate or decline. The costs continue to rise with our overhead, our malpractice, hiring staff. And so private practice has become nearly impossible. There's very few left. Many of us have become hospital employees over the years. There's a dollar-to-dollar mismatch with surgery reimbursement versus hospital revenue for our procedures. And everybody knows now about the CMS's looming 2.5% RVU reduction because we're efficient at our jobs, right? You're doing your job too well, so we're going to take extra money away. Makes a lot of sense, right? So there is this sense of lack of institutional value recognition. The hospitals reward RVUs, not necessarily our outcomes. But hospitals benefit when surgeons have good outcomes. So the message from administration sometimes is, if it doesn't generate a bill, it doesn't count, right? I mean, I was told by my administration, we heard you're going to be president of your society. That's probably going to mean time away from work, right? Yes. Well, guess what? Your salary's probably going to drop. Thank you. The same token, they wanted to advertise the fact that I was going to do this. Does that make any sense? No. I'm not complaining, I'm just stating the facts. So, what's the other thing that we face? Lack of support for fellowship training, right? Fellowship training is why we're really all here. That's what we love to do. We highly value our teaching time, teaching the next generation, which is the backbone of our specialty. The teaching does not generate money. That's okay. In fact, extra time in the OR sometimes, which is necessary to train someone well, is frowned upon by administration. Lectures and teaching rounds do not provide compensation. That's all right. And most institutions do not provide any meaningful compensation for your teaching. But the hospital gets reimbursed for our teaching, right? There's the direct graduate medical education. The hospital is reimbursed for the actual cost of training residents. And then there's indirect medical education costs too. There's reimbursement based on the resident to bed ratio, and this is paid as an add-on to DRG codes. People know about the GC modifier that you can use when a physician provides direct supervision for residents. So the hospital is benefiting. So just for like some of the young people out there, and may not, when I was in training, I learned nothing about economics of medicine. And in fact, when we took our jobs, we really weren't even asking about money. Like, thank you very much. I mean, give me whatever you're giving. I didn't debate it. That's what it was. It's great. I know it's different for the young people now. It should be, right? You should be valued. So what's the CPT code? This is current procedural terminology. It's a 5-character code that identifies the surgical procedure. An RVU is a relative value unit, and it's made up of the physician work RVU, plus the practice expense RVU, plus the malpractice RVU. And each of those is associated with the geographic practice cost index. And then there's something called a conversion factor, which is the dollar amount for RVU reimbursement, which is set annually by CMS, and that's what we keep fighting for. So, and this just shows you how the payment for the procedure is calculated. The DRG is a diagnostic-related group, and it's a classification system used in healthcare group patients with similar diagnoses, procedures, and other practice and puts into categories. And then the hospitals are reimbursed a set amount for caring for patients with a specific DRG. And this is supposed to encourage efficiency of care and standardization of care. So there's there's three different categories of DRGs. DRGs without complications or major comorbidities, DRGs with complications and comorbidities, and DRGs with major complications and comorbidities. And the reason this is important, we're all hassled by the coders, right? And you have to make sure you put down every single medical complication has. And it's painful when they do it, but it's important because if you do your coding properly, we are doing our part for the hospital, right? We're trying to have the hospital be reimbursed as much as possible based on how sick that patient is. So we do have our responsibility. So this is just showing you DRG reimbursement for low anterior resection. So for low anterior resection without any major comorbidities or complications, it's about $10,000. Once you start getting one or two complications or comorbidities, it's up to about $12,000, and it becomes major comorbidities up to about $24,000. These figures reflect our hospital's bundled inpatient reimbursement. This is separate from our professional fees and all the downstream and ancillary revenue that we generate for the hospital. And I'll show you in a minute, this on my next slide, but the surgeon's professional fee remains the same, right? It does not matter how sick that patient is. It does not matter how many countless hours you're taking care of that patient. Our reimbursement is the same. So this just kind of highlights the disproportionate financial leverage hospitals have in terms of revenue capture. But there are penalties that exist. You know about the hospital-acquired condition reduction program. If a complication is deemed preventable, like surgical site infection, DVTs, retained objects, CMS reduces hospital reimbursement. And hospitals in the worst performing quartile lose 1% of all Medicare payments across the board. So again, it's our responsibility to do a good job with these patients. That's us helping the hospital, and obviously our patients. The hospital readmissions reduction program, again, you're all familiar with this. Excess readmissions within 30 days, anastomotic leaks, other infections, leads to financial penalties. And that penalty is up to 3% of all Medicare patients for that hospital. This just shows you, just to kind of make this, look at what the surgeon is making. Look at your professional fee, right, for a low anterior resection versus what the hospital is going to get. Think about that. Looking at colon resections, okay, you have on the left, you have no complications, the comorbidities, the middle, and then the major comorbidities. This just shows you, again, the red line at the bottom is your professional fee. It's the same. It does not matter how complex that patient is, right? It can be a 2-hour case, it can be a 20-hour case. It can be someone in the hospital for 3 days, for 20 days. Your fee's the same. The hospital, which is the blue line, you can see how that goes up. But the dotted black line there shows you, again, our responsibility to do a good job with the patient, not have complications, because the longer they're in the hospital, right, the hospital will eventually lose money. So for a straightforward, colon resection, without any complications, you have to get that patient out of the hospital within about 5 days so that the hospital still is making money, right? And as it becomes a more complex patient, you have more complications, you certainly have more time before that becomes an issue. But it just shows how we all have to work together. It's not just me complaining about not getting enough money, it just shows what the disparity is. So, as you can see, surgeons and hospitals are misaligned. The hospitals benefit financially from complexity in the short term, but they're penalized later for the poor outcomes. The surgeons are financially punished either way. We get the same fee regardless of the complexity, and the more complex the patient is, additional spiritual, medical, legal risk, reputational risk if you have a lot of complications, and certainly burnout. And this misalignment will drive anxiety, so surgeons feel squeezed, hospitals chase the metrics, and patient-centered care value gets lost in the process. Don't forget, as a surgeon, you're creating a lot of downstream revenue for your hospital. It's not just the operation you're doing in that DRG. As a surgeon, especially with rectal cancers, you're bringing in patients to oncology for chemotherapy and radiation. You're bringing them in for imaging, the pathology, all the laboratories, the OR and administrative things. So you're contributing a lot to your hospital with every single patient that you bring through the door. This also applies to outpatient ambulatory patient classification systems. This is similar to DRGs, but this is used to determine hospital reimbursement for outpatient procedures based on CPT codes. So this is separate from the physician fee reimbursement. There are surgical APCs for outpatient surgery, and then there's the medical APCs for things like clinic visits. And many times, that facility fee is much higher than the physician professional fee, especially for like neonatal procedures. And you may have heard that CMS now is going off after the facility fees, right? So that's going to put more pressure on the hospital, which is going to down trickle to you. But this is being fought by the DCS, trying to not have this happen. So again, this just shows you who's really getting paid the most for these common colorectal procedures, outpatient procedures. So for instance, an anal fistula, the surgeon may get $329, the hospital gets $3,000. Hemorrhoid gets you $200, they get $1,300. Colonoscopy, just under $400, $1,200 for the hospital. It just goes on and on and on. This is looking at just clinic visits, right? Let's just say you're seeing 1,000 patients with level 3 to 4 mix. The surgeon will bring in about $220,000, but with that will come $150,000 for the hospital facility fee. Again, looking at anal rectal cases, let's just say the surgeon does 180 anal rectal cases. They'll bring in about $60,000 in the surgeon annual fee. But the hospital fees, again, the facility fees, the pathology fees, it's almost 10 times that, right? This is a real world example. This is a colleague who shared this with me recently. A colleague asked to see their 5-year hospital charges, and this is just for procedures. This is none of the downstream revenue. 5-year charges were $53 million. That was about $10 million a year. And if you assume that the hospital only collects maybe 35% of that, and that can vary location to location, hospital to hospital, but 35% is fair. That's just under $4 million. So let's just assume the surgeon gets paid a salary of $540,000, and then the overhead for that surgeon is $500,000. The hospital is still getting revenue of $2.6 million a year. And again, that is not including the downstream effects that they're bringing into the hospital. So just to kind of show you graphically the same thing, the surgeon overhead maybe $300,000, their salary is $500,000, their revenue is over $3 million, so the net margin for the hospital is $2.5 million for that surgeon. Again, if you look at a different case mix, someone who's inpatient heavy with a lot of rectal cancer surgery, let's just say the revenue may be over $3 million. For someone who's just doing more outpatient surgery or office, it's still not bad. I mean, they're still bringing in nearly $2 million a year for the hospital. And again, if you add on the downstream effects, like I told you with radiology, laboratory, hematology, radiation oncology, those margins become even wider. So this isn't all about money. This is not just to talk about money. That's not what I'm complaining about. It's just that you need to have this information so that you can remind your hospital why you are important to them and why what you say matters. Because the hospital is able to function because of surgeons, okay? And why is this important? Our patients. That's the most important thing, right? colorectal surgeons, we are uniquely trained and we have better outcomes when compared to some of our general surgery colleagues. And colorectal surgeons serve as an entry point for many other hospital services and revenue. Gastroenterology referrals for inflammatory bowel disease, hematology, oncology, radiation oncology for our cancer patients, radiology, pathology, laboratory, operating room utilization. That's unique. Medical doctors don't have that, per se. This is the future of our specialty. It's important because without fellowship support and protected teaching time, how do we train the next generation? Many of our colleagues have seen it over the years. When I first started in practice, everybody could come to the national meeting the whole time, right? Now people, many times, their institution will not support them coming to a meeting to learn the latest technology, or to even just socialize and network with their colleagues. I mean, there was a famous colorectal surgeon, one of our past presidents, who is not necessarily presenting anymore, but is sharing a room with a resident because the institution won't support going to the meeting. That's a little ridiculous, right? I mean, it doesn't make any sense. So with this lack of support for STEAM activity, it's difficult to keep up with the latest advances in the field, and that lack of networking and socialization leads to further isolation and burnout. So what is our path forward? We need to reclaim our value. We must present the hospital system with true value accounting, the full downstream revenue, just not our professional fees. And we need to push back, and it's happening with ACS, on the efficiency penalties. That's a false economy. And then advocacy through ASCRS. And we do that. You may not realize that, but we do that for you. We do CMS engagement. We work with RVU Reform Committee through the American Medical Association. Some of you may know Kelly Tyler. She's very busy, working very hard for us to do better for us. So we do these things for you. They may not even be happening behind the scenes. We need to demonstrate our specialty value. We do it better than general surgery. But what's funny, when I talk to a lot of my colleagues around the country, a lot of times if you're being paid on an RVU pay scale, a lot of times the general surgeons are making more dollar-wise per RVU than us as specialists. Does that make sense? You know the difference between a diverticulitis case for diverticulosis and diverticulitis case for the worst fistula stuck everywhere, right? It's a totally different ballgame. Who are doing those cases? We are. Okay. So we need to protect our people. We need to be able to prioritize surgeon well-being as essential to patient safety, institutional investment in reducing burnout. And I'm not talking about those stupid, wellness and burnout surveys that we have to fill out. Come on, that's just wasting my time. Forget the darn pizza party and the social outings that they want us to do for burnout. No, I don't think so. Do something real to help the surgeons. Increase the OR and office staffing. Increase and better use of the physician extenders. Reducing our administrative burden, okay? Each year, there's more and more and more administrative burden that we're doing. We're not getting paid for that. I mean, we should be, but we're not. I'm basically a biller, a coder, a scheduler. We're all held hostage to that epic patient advice request. I mean, come on. If you were a lawyer answering that many emails from your patients, you'd be very rich. But we don't pay for that. We just do it out of the goodness of our hearts. That needs to stop. Institutional support for surgical society meeting attendance is crucial for education, networking, and supporting and encouraging the next generation. It's crucial. We need to reaffirm our purpose. Fellowship training is not overhead. It's a legacy. And hospitals that support training are going to secure their future. And ASCRS will support your opportunities with mentorship, leadership training, as I mentioned, in public advocacy. So where do we go with all this information? Again, it was not just a complaint about us not making money. We make great salaries, okay? We make great salaries, but we do a lot for it. But we just let the administration know that we're not knowing what we're bringing to the table. We are valuable. It may not be unreasonable to ask for more dollars per RVU. You're probably not going to get very far with that though, because the hospital has pressures too. But ask for other things that may not be RVU related, like flexibility in your schedule. Get me an additional APP. Give me some protected teaching time. Give me protected time and support me to attend CME activities. And protected time for our colors leader and advocates. Take on leadership roles in your hospital. Assume roles as the chief medical officer, the chief of surgery, the president of the medical staff. You want to be on the leadership on the quality and safety committees. And you want to assume leadership roles for your GI centers of excellence. And that would include cancer, inflammatory bowel disease, the pelvic floor and women's health centers, early onset colorectal cancer centers. You know, don't let medicine be in charge of that. Make the surgeon be in charge of that. You have to be informed in the hospital. So I'll say now for myself even, stop the complaining and jump to action. We are all in the same boat to some degree. Know that you contribute more than you're giving credit, and you're not just RVU machines. Know your value and worth and approach in the hospital leadership. And you may not get more money, which is okay, but consider ways to improve your quality of life and push for more opportunities for educational opportunities and leadership growth. There are ASCRS resources that I want to point you to. Our Healthcare Economics Committee does a ton of work on this stuff, and they're very quiet. It's all behind the scenes, but there are great articles related to all of this that you can see on the DCR website under that little room thing that's at the top there. If you pull down legislative articles, they're all in there. There's a lot of good information there. The Gut Check podcast has had several things dedicated to this this topic, which we're really good. There's webinars, and then again we have our Surgical Leadership Institute as well, which I encourage the young people when we have our next one to attend. I want to give a plug to Dr. Mahmood. Her meeting is coming up in Tampa. Definitely should attend. It's going to be a great meeting. Her theme is evidence-based excellence. My meeting will be the next year, which will be a tripartite meeting. So that will be pretty exciting. It's in New Orleans. I don't know what the topic's going to be yet. And the other thing I wanted to bring to your attention and invite you all to participate, there's something called the ASCRS Quality Collaborative. This is a research opportunity for everybody to get involved. This research collaborative is focusing on fistula and ano. It's a REDCap database, and everybody is invited and encouraged to participate. I have Julia's name up here. You can take a little screenshot if you want. She's a lady, but that's who you would contact if you want to get involved, because they are recruiting people actively now to get involved. And it's an opportunity for everybody, no matter what institution or kind of practice you're in, because we all do fistula surgery. And that's it.